think treatment planning is sort of extra special to me because I think we can make such a big difference in patients' lives. I think a lot of times as physicists, we look at these small changes, a few percent here, but treatment planning, you can make drastic impact, not only in each patient's life, but sort of in your whole healthcare system within the country. The trickle down effects of, say, sparing different organs in different patients and how that leads to less medical necessity down the road. So I urge you to practice these techniques. You can take these same principles that we've taught in the Shulman method, and you can apply them in other creative ways just based on the dose fall off. But we're going to teach you this method today. So I'm not going to focus too much on contouring or anything else. I'm going to quickly go through that. And if you have any questions about the contour, you can go back to my last session where I explained it in a lot more detail and refer to our PDF that explains the treatment planning method. I'm also not going to use the the ZOAR in PTV today. I explained that in pretty good detail and showed examples on my last session. So if you have questions about how to use that ZOAR in PTV to sort of spare these mean dose structures while covering as much PTV as possible, again, refer to the last video. Just for the sake of time, I'm omitting this from this particular case. And like Senji said, he's going to share a couple videos of some previous tutorials, another head and neck, which is a little bit more complicated than this, with 3 SIB and some optics involvement, and a complicated pelvis plus periortic session. So that being said, I'll go ahead and get started. So I'm going to quickly review this plan, and I want to spend the majority of this session. It might be about an hour 15. We'll try to get done in an hour, actually going through the optimization. And again, please feel free to ask questions as we go. So here's our original PTV. This is going to 60 gray. The blue is going to 54 gray. And the first thing that we do is turn on the organs at risk. And I'll quickly do that. And we'll just get an idea of what can be spared and what can't be spared and how we want to optimize. Okay, so we'll sort of quickly scroll through. You can see the thyroid is almost entirely inside of PTV 54. We're really just going to ignore this in the optimization. So we're just going to forget the thyroid. Esophagus, it's going to be easily spared. You can see it's outside of PTV 54. Brachial plexus, we want a max dose of 60. Again, I'm going to use some dose constraints. These are not meant to be teaching how to use dose constraints or teaching how to cover what doses to cover with PTVs. These will come from your radiation oncologist. It could be patient specific. You could be using different protocols, but I am going to list some doses just because for the purpose of optimization. But the idea of today is to explain how to treatment plan, not necessarily exactly what doses need to go where. Okay, so in my case, brachial plexus max dose of 60 gray. Well, it's inside PTV 54. So I don't need to worry about it too much. It's not going to go over its max dose. We'll put a max constraint on it, but that'll be easily covered. We've got our pharynx here. I want a mean of 45 or less. It looks like it's going to be quite easy to accomplish as well. Then we've got the larynx right here. Again, mean of 45. We should be able to cover that. No issues. Mandible, we'll want to have about a 5% hotspot or less if possible. It might be a little bit challenging just because we've got so much mandible in our highest PTV. We'll do the best that we can. That could be a little bit challenging. Parotids here, right next to PTV 54 and a little bit close to PTV 60. We should be able to spare one or come close to sparing both. Again, you could use the ZOAR in PTV structures to sort of optimize that mean dose as we go. Again, refer to the last video for that. Today, I'm not going to use that concept. Oral cavity, it's almost all inside of PTV 60 and a lot in 54. We're going to assume that the doctor doesn't want any optimization on it. If you did, of course, you just follow the same principles as I'm going to teach. Then our lips are here. They're going to have a max dose of around 60 gray. All the optics are far out of the way. Brainstem is pretty far out of the way. So is the spinal cord, so no issues with that. We're actually just going to use the spinal cord to optimize the mean dose and sort of push dose back in the back of the neck. Some people put a back of the neck structure. I'm just going to use the PRV of the spinal cord. That should do a pretty good job on its own. Okay, so now looking at additional structures. So I want to make sure that they're about 3 millimeters away from the skin surface, which they all are, my PTVs. That's the first thing. And then we want to make our ZPTV Opti 54. This will be for our max dose within our PTV 54 to separate the two PTVs. Again, refer to this document, right? The planning document that we shared last time. And here we can see, I'll just quickly go over these so we can start the planning. 54 gray divided by 60 gray approximately. It's about 90% of the dose. We've got about a 10% dose fall off. This is a big structure. So big structure means 5% per millimeter approximately at close distances. So we need about 2 millimeters dose fall off. So I'm going to do a separation of 2 millimeters. Here's my new optimization, 2 millimeters away from PTV 60. That way I can limit my max doses here and get coverage on both. Okay, and then we're also going to use this ZPTV Opti 54 in order to look at coverage of PTV 54. So we don't want to use the whole PTV 54 because that's going to make our coverage a little bit easier because it includes some of the higher PTV. Okay, and then we've got our rind structure. So we got a 54 rind. Here it is, just 5 millimeters all the way around the edges of my ZPTV Opti 54. And we've got a 5 millimeter rind for the PTV 60. That's right here, the inner 5 millimeters of my PTV 60, just to help with the edge doses as we're really pushing dose fall off at organs at risk and throughout the body.
Sorry, there's a question in the chat asking about the mask and the positioning device.
Okay, sure. Yeah, so in this talk, we're not going to talk too much about setup devices or anything like that, just for the sake of time. We want to focus just on the planning techniques in order to optimize properly. So I think we got a whole lecture on setup devices. So I think I will refer you to that for the time being. I put in a corner structure. This is just sort of the tougher areas to reach, the corners of this these nodal volumes. And you can see I've ended it here. It gets pretty easy here. So you can just see where the corner volumes are. Honestly, in Eclipse version 15.6, I don't really need these anymore, but when I was using version 13 and lower, I still needed them. They could be helpful in your algorithm. And then the ring structures. So I created a first ring that was 3 millimeters away from PTV, from both PTVs together. And I'm going to optimize 85% of PTV 54 at 3 millimeters away. I'm going to put a max objective. And so if I'm going to have a max objective of 45.9, then I need it to be further than 3 millimeters away from PTV 60. So let's see how much dose fall off this value is from PTV 60. So we'll divide by 60. It's about 23.5 gray dose fall off. 23.5% dose fall off from PTV 60 to my first max constraint on this ring. So again, 5% per millimeter. So 23% dose fall off divided by 5% per millimeter, 4.5 millimeters. I subtracted 5 millimeters. So the distance from here to here is 5 from PTV 60. The distance from here to here is 3 for PTV 54. And it's going to have a max constraint of 45.9. That's 85% of PTV 54. Okay. And then ring 2 just is contiguous with ring 1. I'm not doing any additional subtractions. It's far enough away, it'll be okay. In addition to that, most of ring 2 is sort of at the skin surface or outside the patient with PTV 60, but it's far enough away, it'll still do an okay job. And the last thing, we got the shoulder avoidance. So I've just contoured the shoulders, and I'm going to avoid entry through the shoulders. If you don't have an avoid entry option in your treatment planning system, there are other ways. You can just put a really hard objective on it. In my previous tutorial on head and neck.
Sorry, can I ask a question?
Sure.
Thank you very much for your presentation. I have one question. This is related to the eclipse, your explanation. But for the Monaco, there is one cost function. It's called quadratic overdose for the body, for the patients.
Okay.
And there is a margin. So are you recommending or suggesting to have 5 quadratic overdose for the body, for the patient? We say patients in some center, and we can say for the body, and for each millimeter 5% dose difference. It means, for example, for prostate hyperfractionation, 60 gray in 20 fractions. If I want to have a zero margin at 60-degree quadratic overdose, then decreasing until I reach it to the below 20 or 10 gray. Are you suggesting to use every 2 millimeter or 1 millimeter, 1 quadratic overdose, and decreasing the dose by 5%?
Good question, Javier. So I am not familiar with Monaco. We are going to have a Monaco treatment planning tutorial next weekend. And so some nuances of Monaco will be addressed then that I think I won't be able to answer to the best as well as you'll need it answered. But in general, so again, I can't tell you anything particular about Monaco, only what the sort of rules of thumb are in terms of dose fall off. So I think next weekend, my colleague can address your questions perfectly for exactly how to handle it in Monaco.
Yes, but for Eclipse, I want to understand your method for Eclipse. Do you use any cost function for the body? For the body means from the target to the body. Do you use any cost function?
So in Eclipse, there's a certain, we'll see it once we enter into the optimization. I do put in a cost function for the body at 0 millimeters away from the target. And it's got a sort of exponential drop off, which I'll show you that equation once we enter into the optimization. I'll show you exactly what that is.
Okay.
Yeah.
Thank you very much.
Yeah. Thank you, Javier. And so on my previous tutorial on head and neck planning, which Senji is sharing with you, you will see how I've optimized without any sort of algorithm being able to do a void entry. So I just put really hard constraints on the shoulders, and I was able to achieve it similarly. So if you're curious about that, you can watch that other video on YouTube. So in this case, I've just put shoulder avoidances. I'm going to use my optimization algorithm to avoid entry through the shoulder. Okay, so we are going to, and then I'll just quickly show you beam's eye view of my arcs. I only use 2 arcs. I can mostly get away with that just for sort of patient throughput. Just keep in mind that if you do put additional arcs in your patient, it just makes your optimization easier. You can get better dosimetry with more arcs typically. It's just time versus quality. So I'm just going to show you with 2 arcs and show you that you're actually able to accomplish quite a bit with even 2 arcs in complicated targets. And I've limited my X jaws. The MLCs can only travel a little less than 15 cm, so you don't want to go too far over that, at least for this particular machine. You want to think about your MLC leaf travel. So I've just optimized that slightly more than how far the leaves can actually travel, but not too much more to still be able to optimize it well. And just made sure that the target stays within. If it doesn't stay within, the optimizer can still optimize it well, or you can use different beam techniques, which I won't get into in this session just because it has been covered in other sessions. So I'm going to quickly jump into the optimization so that we can get to the training on exactly how optimization is done. And again, I'm demonstrating on Eclipse. There will be some slight differences in how your algorithm or how your treatment planning system deals with this. And Javier, for example, next week, you'll get some explicit answers on how to use it in Monaco. But again, I'm teaching by principle. So the principle should be pretty close no matter what planning system you're using. Okay, the principles of contours, that's the same for every planning system. And then how I'm going to optimize should be very similar for any planning system, just because we're looking at sort of slowly massaging the dose in the large MLC motions. And then once those are sort of set, and then fine-tuning the MLCs. And the concept is similar no matter what the treatment planning system. So focus on the concepts more than just the keystrokes that I'm doing. Okay, so quickly, we've got starting objectives here. PTV 60, we've got a fake objective at 95%. I'm sorry, 95% of the volume being covered by the prescription. This is what we're trying to achieve. I want a V100 of 95%. Same with my PTV 54. I've got that fake objective. It's got 0 weighting. And then I start with 100% at 1% higher than prescription and 0% at 5% higher than prescription. And then this is for Eclipse users only. This, again, this fake upper objective, which is the same as the lower objective. And this is for Eclipse only, just because with our normal tissue objective, this start dose of 100%, that start dose is percentage of your lowest upper objective. So these are upper objectives. This is my lowest upper objective. That's the same as my prescription. So start dose of 100% means start dose at my lower objective. That's all that means. That's for Eclipse users only. And I put these objectives on all of my PTVs, so PTV 60, the Opti 54, the corners, the Rind for 54, the Rind for 60, and then I got my rings. This is 85% of PTV 54. This is 65% of PTV 54, as explained in the document. I got my shoulder avoid, and I put a no entry. In Eclipse, you have this. Again, there are other options. You can just weight it really heavily. You don't have this option in your treatment planning system. And I'm not going to put any objectives yet on my organs at risk. We'll get to that shortly. My normal tissue objective, this is Eclipse users only. Again, the way that I start, priority of 200, 0 millimeter margin of dose fall off from the target, 100%. This means no conflicting arguments. The dose that we want for the PTV is the same as where we want the dose falling off from the PTV. And the end dose of 40% with a fall off 0.3. So this is Eclipse users only. You may have something similar. If you don't have any of this objective, your rings will work just fine. I've planned with only rings and no normal tissue objective. It does equally well. Okay, so not a big deal if you don't have that. So I'm going to go ahead and start the optimization. And again, Eclipse looks a little bit different. Don't get too stuck on what it looks like in Eclipse if you don't have Eclipse. The idea in Eclipse is these different MR levels. These are different complexities, basically, of the MLC leaves. So it starts off at the lowest complexity and increases. So this is early on in any optimization is where you can do larger motions of your MLCs. This is where you'll sort of block major sections of your arc angles or of your static gantry positions where you're blocking, say, a parotid or the spinal cord. And then later on, we just want to fine tune those MLCs to get coverage of PTV. Okay, so I'm just going to turn on a couple of these. Oh, I also put a CTV in here at 1% higher than my original objective. So 100 at 1% higher than prescription. And this is 100% coverage at 2% higher than prescription. So I put that in as well. So we're just going to turn on a couple of these. Here's my Opti 54. I'll put on my rings. And this is our sort of error function. And so it looks like it's starting to flatten out. So in any optimization, you want to sort of wait till any parameter adjustments that you've made begin to flatten out, that the optimization has done about all it's going to do. And then you can move on and input the next value. So it's already flat. I paused it before we move on to the next stop. I'll do most of my optimization early on. This is where I get big MLC motion. So I want to do most of it here. So there are two things that we're going to look at. So I'm going to start one, you can sort of get an idea of what your rings look like. They should sort of look like this by the end of your optimization. And so now we will start adding slowly organs at risk one at a time. So I'll start with my most important organs at risk. My left and right carotids. I'm going to turn off my rings right now so you can see a little bit better. And we're just going to optimize with mean constraints only. And so this is about 32 gray. So the way that I optimize is I'll usually start with about 4 gray less. At 150 weighting. And I'll do the same for the right parotid. About 4 gray less at 150 weighting. And we're going to look at two things. We're going to look at this shoulder. And some of the differences will be on your planning system and your version, how much the shoulder drops. 15.6 in Eclipse is pretty powerful. It does a pretty good job. And if you don't really change these weightings, if you follow my weightings, it's going to do a good job and you're going to get to the point that you want to get to. So the other thing that we look at is how close do these values get to each other. So the shoulder didn't drop much. This came really close to the same value. It's within 60 centigrade. This one's within 90 something centigrade. So it was able to achieve it pretty well without the shoulder dropping. That means it didn't mess up the PTV in order to optimize the carotids. And it achieved it pretty easily. So we'll go ahead and drop it some more. So let's drop this one to another 4 gray. Let's drop this one. This one's 100 away, so we'll drop this to like 3 gray less or so, and we'll see how it does. Once these become stationary at about 1.5 gray away from each other, that's a pretty good indication that you don't really need to push much more at that level. So right now it's about 2 gray away. This one's about 2 gray away. I'm not going to push it anymore. It's been pushed enough at this level, leaving these weightings the same. You don't want to touch these weightings. Targets are at 200. OARs are at 150. Normal tissue, if you have Eclipse, is at 200. Leave all these weightings alone. Just optimizing this process, it'll work out. Okay, so we're sort of done with the carotids for now. We'll come back and look at them, and we'll look at these other organs at risk. So our max dose constraints, we're not going to worry about those yet. So that's the mandible and the 2 brachial plexus. We'll get to those later on with fine tuning of MLCs, but we can just sort of one by one add mean constraints. So you're going to do this. So this is at 39. So we'll go to, I went 5 gray less, but usually about 4 gray less. I can count properly today, and we'll just start adding these one by one. So the larynx, and we'll keep an eye on the PTV shoulder. It's still looking okay. It's a very methodical process. It's just a little bit slow, but we'll get to the point that we want to get to. And again, most of your work is going to be done early on, and then later we're just going to sort of fine tune it.
Dr. Shulman, as you're tuning these, I have a private message question. So Tenant was wondering why we should avoid the shoulder beam entrance.
Oh, great question. Brainstem is far away. I'm going to forget about this. Sorry, 1 second. Let me just add this last. Spinal cord, PRV. Again, this will sort of help shape that neck dose. Yeah, great question. So the biggest importance with avoiding the spinal cord, avoiding the shoulders, is if, let's say you've got PTV, lots of times we will have PTV that goes close to the spinal cord. And you've got a sharp dose fall, but you might have high doses near the spinal cord. And that includes beams going through the shoulders. So if the patient loses weight and the shoulders drop, now you've got beams coming in right where the shoulders used to be, but now there's no more tissue, there's no attenuation, you can have a big increase in dose. And that increase in dose can be right at critical organs. It can be in the spinal cord, for example. We had a patient that we had to replant at our hospital before we implemented shoulder avoid, that the shoulders dropped with weight loss. And we got probably a 5, 6, 7% increase in our PTV dose at that area. And that was right where the brachial plexus was. And so we had to replant it because the shoulders dropped and we had a lot more fluence going in, and we got an overdose of our brachial plexus. So it's easy. Usually at the shoulders, it's just these nodal volumes. They're so easy to cover without having to have all those degrees of freedom. That's best just to avoid the shoulders. Really good question, though. So we're going to take a look at these organs at rest. We're going to see what's within 150. You can see our shoulders starting to drop a little bit, but we'll look at the ones that we can still optimize. So this one, the esophagus, actually went lower than even what our objective is. So we can definitely lower this. It did even better than what our objective was. This one is within 50 centigrade. We can drop it lower, another 3 gray or so. This is within 75 centigrade. We'll drop it a little bit more as well. Carotid, it's about a 1.5 gray. We'll leave it. This one, a little bit less than 1.5 gray. We'll leave it right now. Larynx, within about a gray. We can leave it or we can drop it a tiny bit more. We can get to it in subsequent iterations. And then the spinal cord, we've achieved it pretty well. Let's drop it a little bit more. Okay, so then we've pushed it a little bit more. We're going to let it sit. We're going to let the error bar error bar flatten out, which means that we've pushed it about as it's optimized everything that's going to optimize. Our shoulders dropped a little bit, so that's probably about all that we're going to optimize in this level. Then we're going to unpause it and let it go. And we've also pushed them all. They're all about a gray away. Here's a gray and a half. Again, 1.5 gray, close to 1.5 gray. It looks like we've pushed them all pretty well. 21, 22, 72. Okay, they're all about 1.5 gray away from each other, except for esophagus. So let's go ahead and just push the esophagus one more time. It's pretty far away. It's pretty easy to optimize. We can push the esophagus. You can see the esophagus is dropping quickly, but our shoulder didn't really move as our esophagus is moving. Okay, so we can see that we can really drop the esophagus. And so we'll go ahead and move on to the next level. We might be able to drop our esophagus even more, but we'll just move on for time's sake. So I've unpaused it, so it's going to keep moving on in the sequence. And so Eclipse has this visual. I don't pay much attention to this, to be honest with you. This can be just a little bit misleading on where you're going to be at the end of the optimization. So if you are an Eclipse user or any other user and you have this visual, don't pay much attention to it. The plan doesn't look amazing right now. I know where it's going to be by the end. So right now we're doing gross MLC motions. By the end, we're going to fine tune it. This is all going to be really nice and smooth. So don't pay too much attention to this. We know when we've pushed the organs at risk as hard as we can by this gray and a half difference and by where the shoulder dropped. So you don't need to pay too much attention to this. We can basically see our dose distribution just by looking at our DPH. Okay, so it moved on to a next level. So we've got an increased sophistication in our MLC. And so we saw a big jump in our error. That's because of in Eclipse, sort of the interpolation by going from a few static fields with segments of MLCs and moving to more fields along my arc angles. And now it's redoing those MLCs between the two sort of gantry positions. Again, we're just increasing the number of degrees of freedom as we go in this Eclipse system, but the same concept of major motions to smaller motions. And we're going to get back to about where we were in the previous step, just waiting for this error bar to go down. So the idea is that this should be a really methodical approach. So if you spend time and you get your contours exactly the way that you want them, and then you just sort of slowly, one organ at risk at a time, move on to the next level, one organ at risk at a time, you'll get to a really good result in the end. And you don't really need to mess with these weightings. I'm probably going to record on my own another tutorial on a large pelvic mass VMAT plan, just to have another one if you all are interested in viewing. And that covers both max doses to small organs at risk, like the spinal cord, and also max doses to large expansive organs at risk to see how those are handled differently. So I'm going to try and record that in the near future as well. So right now we're just waiting. So again, a lot of our optimization will be done early on, and then as we move forward, we'll fine tune those MLCs. So you don't want your shoulder to drop too much. If my shoulder dropped all the way down to here, that means that we just pushed everything too hard. We've only dropped a little bit from about here. Probably we were just below this 95. We only dropped from about here to here. We haven't dropped our shoulder much. Again, we don't want to have drastic drops in shoulder. It just means that we've done too much optimization. Okay, it's starting to flatten out, so we can start looking at our organs at risk again. Esophagus, easily achieved. It's right at the same dose level, so we'll drop it another 4 gray. Larynx, easily achieved with our new more degrees of freedom MLCs. We'll drop this another 4 gray. Lips, easily achieved. Drop it about 3 gray. Carotids, they've gotten a little bit better. We'll drop them just a little bit, just especially because we really want to push carotids. This one's still not too close, but we'll drop it like 1 more just because our carotids are a little bit closer to our mean doses than are some of these other structures. So these, we will plan at my institution usually a mean of about 45 for a lot of these, and they're way low. Our carotids are a little closer to what we're trying to achieve. We usually try to get a mean of about 24. So we may not succeed with the left carotid. We will with the right. Again, if your doctor was willing to sacrifice PTV coverage, you could always implement the ZOAR in PTV technique. And again, I'll refer you to the last video. You can always glance at your rings. This looks about the same. If you turn it on, looks about the same as where we started. Same with ring 2. Looks about the same on the DVH. If you're curious. The spinal cord is cutting close to achieving it, so we'll drop it maybe 3 gray more. And again, we just keep continuing this process, looking at our shoulder. It hasn't dropped much, and that 1.5 gray difference. So esophagus keeps easily achieving, so we'll just keep dropping it. And larynx, pretty easily achieved. We'll just keep dropping it. The lips look like they're sort of, can't really push it anymore. It's a little over 1.5 gray. Both the left and right parotids are at 1.5 gray. We're going to leave them. And the pharynx, it's achieving better than even what we've done. So let's drop that as well. Another 4 gray. And spinal cord is at 1.5 gray, so we'll leave it. I hope everyone is starting to see a pattern in how we're optimizing. Again, if you look at the isodose lines on here, you think, oh, this is a terrible looking plan. Again, trust the process. It'll look really, really nice by the time we finish. And again, these max doses, we'll focus on a little bit more in section 2 and mostly in section 3 on these 3 max doses. And these are inside of PTV 54. They'll easily achieve their max of 60. The Mandible, again, like we said, it might be a little tricky to achieve that 5% hotspot. This might be one of the very few cases, just because the amount of Mandible in there, that you might have to do a tiny little tweak on a second iteration, but most of the time you'll get a perfect plan on the very first optimization. So we'll see how we do. Okay, let's take a quick glance. This is getting a little less than 1.5 gray, a little less than 1.5 gray, 1.5, 1.5, 1.5. Larynx, easily achieve. We'll drop it another 3 gray. Esophagus, easily achieve. We'll drop it another 3 gray. Again, our shoulder hasn't changed much. Okay, so we're looking at shoulder and this difference in mean dose. And we'll just keep dropping. Pharynx, we can drop it a little bit. And don't worry about this dose spillage. See a little dose spillage here. Again, we are going to clean that in step 3. It'll all look really nice by the time we finish. Okay, I'm going to go ahead and unpause it. You get the idea, and we'll move on to the next step. I'll try and finish in a reasonable amount of time for you all. I'd say in about 20 minutes or so. We'll finish this plan and we'll calculate it. So we should get out approximately on time. Again, maybe we might go 15 minutes over or something. But so again, we've moved in complexity, and there's, in terms of eclipse, we just saw there's an interpolation between where the MLCs were, and it just interpolated between, and now we're sort of re-optimizing those MLCs again as the error drops. That's what's happening in Eclipse right now. So we'll just wait a minute and shoulder will come back up. Does anyone have any questions right now about anything that we've done so far?
Dr. Shulman, I think there are a few questions in the chat, but it seems like some of them are referring to the previous ones. Just tell me when to stop if I...
Okay.
So I have the question says, can you explain how each MR levels works during optimization?
Okay, yep, so this is an Eclipse thing, so I don't want to get too stuck on how Eclipse functions versus how other planning systems, just because we have other users here. So the main point I want to make is with any optimization algorithm, you're going to start at big MLC motions, and we're looking to massage it into local minima. And then we'll show you how to lock in those local minima and fine tune MLCs near the end of the optimization algorithm. So no matter what system you use, that's the process that we want to go. In Eclipse, these different MR levels, I don't remember exactly now. I used to know, but I think in MR level 1, it starts out with like 7 gantry angles. Don't quote me on this. I could be a little bit wrong, but it starts off with a limited number of gantry angles, and it optimizes the MLCs. And then it moves on to a subsequent step, and it doubles the gantry angles. And then it optimizes those. And then it doubles the gantry angles again, and optimizes those. So again, you're starting with these rough big coarse MLC motions. And as you go further, you start fine-tuning the MLC motions. So that's sort of the general idea without getting into too much detail about these different levels within Eclipse.
I
But the
see.
same concepts apply to all planning systems.
Another question is, would you mind repeating the start dose and the end dose in NTO?
Oh yeah, sure. So it's on the treatment planning sheet that we've handed you. So make that your friend. But here they are here. Again, a priority of 200, 0 distance from the target, 100% to 40% at 0.3. So remember, this 100% is only working because we put that dummy lowest upper objective here at the same as our lower objective. And we've got a dummy because it's 0 weighting. So that's Eclipse users only.
Yeah, well, I got a few requests about in private about the treatment planning sheet, but it seems like I don't have it either. So maybe when you have a moment, I can share it to everyone.
Yep, sure. I'll send it to you. Maybe you can email it to everybody right after, just to make sure that everyone has it.
Yeah, that'll work. Yeah, because just got some like private ones. And yeah, I'm not sure if you have more time, but also what are the bases to decide the priority values of the NTO, I think?
Yep, so this is just sort of trial and error, and it works. So you can I urge you to start with the process that we've developed. If you want to adjust it, fine tune it based on the principles that we teach, that's great. But just sort of trial and error, we found that if we start with targets at 200, NTO at 200, organs at risk at 150 and follow this process, it works well. If you want to deviate from that and you find something that works better, that's great. But definitely the process that we teach, it does work. So if you want to at least start by following this process, I'm pretty confident that you'll start getting some really good plans.
I think the next question might be covered previously. How do you determine the collimator angle for head and neck cases?
Yep. So good question. That was covered in a previous session, so I would refer you to that. There are so many different variations of what collimator angles I would use when. In this case, I only used 10 degrees, plus or minus 10 degrees, just so that I could fit my PTV into the field. If you go too far of a collimator angle, sometimes you'll miss field on one side for extended sup inf lesions or tumors. But there are times, like in the large pelvic mass case that I'll do a planning demonstration with. There, it's much wider than 15 cm. And so I actually used I sort of offset to one side with my collimator angle and then offset to the other side so that I could have multiple arcs covering it. And at the end, I can just pull that one up for you and show you, but there are just a lot of different variations. The main thing is that you just don't want 0. I'd say a minimum of 10 degrees. And you don't want 0 because that leakage radiation through the MLCs. That can be a little bit different when you get into SRS and SVRT, just because of the small field sizes, but for non-SRS SVRT, something at least greater than 10 degrees. Okay, so you can see, I'll answer some more questions in a minute, but you can just see, I just wanted to point out, these are all about 1.5 gray or bigger mean dose differences. So I'm not really pushing any more at this point. I'm just sort of letting the optimization go. And we'll start looking at some max doses in step 2, and then fine tuning of our MLCs to get PTV coverage in step 3. So I'm just going to let this level out. I'll move on to the next step. Do you have more questions, Senji?
Yes. So I think next one is, why do we write some of the upper constraints without priority?
Yep. So again, that is only for Eclipse users. So the only reason I have this upper objective 0.54 with 0 weighting is because my lower objective, what I'm pushing for, is that same value. So it's only for Eclipse users. And that's only because the NTO in Eclipse. So the NTO, this percentage, the start dose, is the percentage of the lowest upper objective. And so if I didn't have this 0, this fake one, my lowest upper objective would be 5% higher than prescription. And so my start dose, then if I put 100%, it would be 100% of my lowest upper objective, which would start falling off at 5670. Well, we don't really want that. So if you didn't have this upper objective, you could put this start dose at 95%. So 95% of 105% is about 100%. It's just a little confusing how Eclipse handles it, but that's the only reason. Good question. And again, Eclipse users only. So it's not quite done, but in the sake of time, I'm going to go ahead and unpause it just to move so we can move on to the next steps and finish this optimization. And I will ask any participants out there, if any of you all have any particular skills in computer programming or scripting, there are some projects that I'm working on and that hopefully I'll be working on with University of Colorado on some really cool uses of this planning technique, but with global implications. So I've got some really cool projects I'll be working on, research, but mostly it's clinical impact. So some really cool projects. So if any of you all, I'm not strong at all. I actually have no knowledge in scripting and computer programming. So if any of you all do have some of those skills and are good at it and have any interest in the sort of global implementation of some really cool treatment planning techniques, feel free to reach out to me. We could always collaborate. Okay, this is leveling out, so we'll go ahead and move on to the next MR level. And I promise you we're getting there. We're getting pretty close already to a finished plan. Our organs at risk are about where we want them to be. We're going to fine tune some of these max doses and then fine tune PTV coverage. Again, if you want, you can always look at your rings. You can see where they are, click them on and off. There are too many structures. You can see they're about where they were when we started. All right, we're going to let this settle back in. So in this case, I'm not looking at any hard stops on organs at risk. So things like cutting the PTV to spare spinal cord PRV, something like that. Again, I will refer you to the YouTube videos that I've recorded previously that Senji's going to send you, where I have done a much more extensive disease. So I had to spare optics, I had to spare spinal cord and brainstem. I had to do those particular subtractions in order to achieve that. It's a much more complex plan. So if you want to see that, I would highly suggest that you look at that YouTube video as well. And hopefully it will be helpful for you. All right, take a quick glance at all the organs at risk are still about 1.5 to 2 gray different. So again, no more pushing on organs at risk. We're done with that. This is starting to level out. So we'll start looking at what these max doses are on these 3 structures. And we can start the process of massaging those doses now. So 54, 56, 70 is 5%. So let's see if we can limit these brachial plexus a little bit lower. Shouldn't really affect too much. Again, this one needs to be lowered a little bit. It's getting close to the max and it shouldn't be there. And the mandible. So 6,000 times 5%. We want this at about 6,300. Right now it's about a 10% hotspot. We can make these a little bit higher. They're just max doses. It's not going to affect the ETV too much. And we'll probably start pushing these a little bit more later. And I might just put something equal to the prescription just on these. And in step 3, we'll push these a lot harder. So I'm just going to let step 2 complete so that we can quickly get to step 3. And I'll show you the fine tuning of MLCs, where we're going to try and fix these max doses. So here's the mandible here. We just need to fine tune it and get it a little bit lower. And we'll fine tune these shoulders. And preferably we'll hold all of these DVHs exactly where they are while we fine tune. Just going to pause it just for a second, just so that it steady levels out again. Then I'll unpause it and we'll go on to step 3. Any more questions?
I think, Dr. Shulman, I think we have a taker on your project.
Okay, great.
Nkeyeshu from Ethiopia. So
Awesome.
I would encourage you to reach out to Dr. Shulman directly in the private message so that at least we have a contact.
Yeah, definitely.
Yeah.
Let me send you my email address too.
Yeah, thank you.
Yeah. And I'm going to send you the planning tutorial. Okay. Did you get the VMAT planning guidelines as well?
Yes. Yes.
Send that out to the whole group. Make sure everyone has it. Thanks.
Okay.
Okay, this is sort of leveled out. We'll go ahead and move on. We'll let it continue to step 3, and we'll move to this, one of the last steps in our optimization process. And so I see a question on with PTV 70 gray, what will be the max dose constraint for the mandible? So I don't want to give you particular clinical dosing advice. This will come from your radiation oncologist. So you need to ask your radiation oncologist. This will be dependent on what protocols are followed. I will also remind you, and different radiation oncologists have different preferences on that, but I will remind you about the differences also between type B and type C algorithms. And so this was also covered, but for the same photon fluence delivered, so the same MLC shades, and you deliver a plan, if you calculate it in type B, and then you calculate that same plan in type C, the dose to the bone will appear, 3 to 5% low. So that being said, if you're optimizing in a type C and you get the same dose distribution that you get in type B, that means that you're delivering about 3 to 5% more bone dose or mandible dose than you would historically using type B. So again, keep that in mind, have that discussion with your doctors. There are places that intentionally keep the mandible extra cool, spend extra focus on that optimization process. But I will leave those exact values of what's desired clinically to your radiation oncologist, or refer you to different literature out there that has those different studies with different dose levels. Okay, we're in step 3. So now step 3 in Eclipse, or just in general, when you've gotten all your gross MLC motions, and now we're at all these local minima, we want to lock in those local minima and just use fine tuning of our MLCs. So at this point, you're not going to go and say, oh, I forgot to block out my parotid. Let me just put a big weighting on that. It's going to change everything. We just want to fine tune those MLCs at this point. So we're just going to let this settle in. And then what we're going to do, one by one, we're going to put big H objectives on all these OARs. And we're going to sort of lock them in place. And then we're going to increase the weighting on our target structures and our max dose structures to fine tune these shoulders and these max dose points. So as soon as this settles in and gets to where not much more is happening, we're going to start adding those constraints. So let me turn off all my OARs, and I'll start adding in shortly, one at a time. You can see the shoulder avoid down here. So again, you can just put, if you didn't have a void entry, you can just put a big objective on this and achieve the same thing. Okay, it's starting to settle in, so I'll go ahead and start putting these on. So spinal cord, I want to lock this in. So I'll put a couple upper objectives. All right, and I'll weight them 300 each. It's not pushing anything at this point because it's already achieved it. All it is locking it in and preventing it from moving forward when I fix these shoulders. I'll do the same with my rings. You can do anywhere from 2 to 3 of these. Again, just because I'm putting them on the outside, it's not pushing anything. So this big weighting isn't really affecting anything. It's just locking them in, preventing this curve from moving forward. I'll do this with every single one of my OARs and my rings, one at a time. So this one, I might put 3 on there just because there's a little curve. Let's lock these in. These were sort of calling our anchors. And again, my DVH objective, different doctors will have different objectives on what they want to accomplish in terms of coverage and dosing. So again, I'm teaching the principles of how to plan, not necessarily dose levels. So in my case, I'm going for a V100 of 95%, but again, you can use the same principles if, say, your doctor wants 95, 95. I've had different doctors that prefer different concepts, and even the same doctors that prefer different coverage for different disease sites. Perfectly normal, but the main idea is just that you understand the concepts of how to plan. Okay, so we are almost finished. All right, all of these are locked in. So now we're going to fine tune coverage and our max dose constraints. So I'm going to go ahead and turn all of these on, and all my PTVs, I'm just going to increase by 100, the max and the lower. You're going to start seeing that shoulder get fixed. And you can see if we put on the rind, you can see that's the lowest one. That's where it's struggling the most. That's right near all the organs at risk, that rind, and that's right near that body dose fall off. And same with the PTV 60, the rind is the lowest one. So we've predicted that the optimizer is going to struggle the most right at that 5 millimeter rind. And so that's why we've created this contour. So you can put a little extra weight on the 2 rind structures, because that's where the optimizer is having the most difficult time. And we can increase the weighting on some of these. Yeah, let's find our mandible. Okay, so we're getting close. Here's our PTV and here's our objective. So we're getting close to what we want. It looks like the 60 gray one is almost there, and our 54 gray is also almost there. We're just going to increase the weighting a little bit more on this mandible. Again, this might be a little bit trickier to get that mandible because of how much is actually in there, but we are lowering it some. And you can also help it a little bit by putting just another tiny structure on there. And you can see the mandible DVH right here. It's beginning to separate from the rest of the PTV, which is what we want to happen. But we've still got coverage of our PTV. And that mandible is starting to get fixed. Now we'll look at, again, just adding a little bit more weight to our PTVs. It doesn't quite have coverage. And we'll look at one other thing. These are okay for me. They're right just over above 5%, and they're well within the tolerance. So I'm not going to push these any harder. They've gotten what I need them to get. Our mandible is getting better, and our coverage is getting better. So let's turn on some of these and see if any of them are hindering our optimization a little bit. So this one, see, it's pulled up over this. So I'm just going to move this out. Our esophagus is well spared. You don't need to worry about that much. It moved a tiny bit, so we'll just relax those back slightly. And we'll see if any of these are holding up our dose. So we can see our larynx. You can see these have 300 weighting, but it's starting to push beyond. And I think that means that it's conflicting. These are conflicting with coverage of our 54. So we're just going to relax these a little bit. We've got really good coverage of our larynx. So we'll just relax these a little bit. It'll just help fine tune this shoulder ever so slightly at the level of the larynx. And we'll just go through one by one. So we've locked them in. It's done a really good job. They're all well spared. So we'll just relax them just slightly. But if you didn't lock them in, they could just move drastically. So we don't want to waste all of that time at the beginning. Our parotid, we'll leave this one. We're not going to relax the parotid just because it's already too gray over my constraint. The right parotid is spared, but we won't relax that one either. We'll look at the pharynx. So you can see this one is really struggling. So I think this one's hurting my PTV 54. Again, it's well spared. We're just going to move it a little bit, especially this high dose one, which right here is the high dose of the PTV 54. So there's probably just a tiny bit of overlap, and we'll move all of these up. We held it in place. Now we're just going to relax it a little bit just to help the coverage of our PTV 54. And our rings, they're fine as they are. And spinal cord PRV, we spread it really well. You can relax it a little bit. It's fine. Because all that back of the neck is reduced significantly. Okay, so I think we're almost there. Maybe a tiny bit more fine tuning. Our mandible constraint now is at 64. So this 0.1 is more representative than 0. The 0 would be a tail. 0.1 is probably more representative of your 0.35 cc's or 0.035 cc's. I'm sorry. So 64 divided by 60. About 6%. It'd be nice if we could reduce it slightly more. And you can see my PTVs, which if I take off my rind structures and my corner structures, which we didn't really need in this case, my PTVs are almost there. we could probably do a slight normalization at the end to get it right. I'm going to go ahead and hit continue. You could always fine tune just a little bit more as we go, but for the sake of time, I'm just going to complete this optimization. We're already almost 15 minutes over. I guess we started about 5 minutes late, so I'm about 10 minutes over, but I'll just finish this out real quickly just so you can see. Just keep in mind that you can always just spend about an extra 10 minutes just in step 3 and 4, just fine tuning this shoulder and these max doses. So I won't perfectly get it right now just because it'll take an extra 10 minutes or so, but I think you all get the idea. We're pretty close to a completed plan. And I didn't notice my body sort of disappeared from here. So I'm just putting a little bit more weighting on here just to make sure that my body is still working hard on dose fall off. If you don't have this, then you would just use your ring structure. And you would just increase the weighting on your ring structure slightly. Okay, so in this case, you can see that 5%. So I've optimized for 100% coverage. And so my 5% hotspot is a little bit high, but my 6% is down below 10% probably. So we're sort of where we want to be. There's a really steep drop, a sharp dose fall off. So sort of depending on your own doctor's preference. I'm just going to let this flatten out. Again, we may not have the perfect plan, but we're almost perfect. Again, another 10 minutes or so, just fine tuning these shoulders ever so slightly and these max doses ever so slightly. And we could get exactly where we want. I'm just not going to spend that extra 10 minutes to get the perfection that we want right now. But I hope you all get the idea. I really just want this to go ahead and complete, so we can calculate the dose and just take a quick look for a few minutes. Any other questions? We probably got about 5 minutes left before this finishes up.
I think we have one. Do you use the GUED base priority?
Yeah, so I do not here. I think someone asked me that on the last course. This, I think, is just an eclipse concept. And right now, I am not using this. I'm strictly just going by DVHs and this optimization process in priority. Again, the idea with this concept of planning and this tutorial is to give everyone, no matter what their planning system is, the concepts for how to create a really good plan really quickly. And Eclipse users also, if you follow this plan, honestly, there aren't none of the AI is able to achieve better plans than this process. Anyone that I've taught at my respective centers, when they plan this way, it's just really difficult for anyone to achieve better plans than these, to be honest with you. And it's a pretty simple process. That being said, we teach these principles. If you want to use the concepts that you've learned and extrapolate and make additions and improvements, I think that's great. So I think there are always ways of making improvements. And there are ways, I mean, we could use the same concepts of dose fall off, and we could generate a lot more organ at risk contours, and we could do organs at risk inside the PTV or outside the PTV. We could do subtractions 5 millimeters away and put max doses on parotids, that sort of thing. But again, that just becomes a much bigger workload if you don't have scripting. So this process of just creating contours for PTVs only, putting mean objectives, it works really well. But I definitely, definitely experiment with it and try to improve it. I think that's great as well.
The next question is, when PTV is for PTV 7000, what will be the max dose constraint for Mandible?
Yeah, so I think I read that one earlier and answered that one. That will be physician preference, I think. I don't want to give particular clinical advice on exactly dose constraints or dose objectives on PTVs.
Mm-hmm. Yeah, I think in that case, we see if there's any new ones.
So this is finishing up. Hopefully it'll finish its calculation. We can look at the final dose distribution, but you can see, well, now it just went to step 4, but you can see our coverage, our DVHs are quite sharp. Our coverage is quite good. Our organ at risk sparing is quite good. Again, here, we could probably sharpen up our curve just slightly. Again, a little bit lower max dose, a little bit higher shoulder, just playing with the weighting a little bit more. And we could improve this mandible dose a little bit more too, but I'm already over time. So we're just gonna finish the calculation. And again, in this case, with this prescription level, you'll see the 6% hotspots, pretty small, about 10% of the volume. The 5% hotspots might be a little bit high, but that's sort of based on the prescription that I'm going for. But again, we could slightly improve that sharpness of the shoulder a little bit.
Question. So since you mentioned AI, what would you think about rapid plan versus what we are doing right now in terms of clinical?
Yeah. So I've dealt with a lot of institutions that use rapid plan. I think it's a great tool. It's still based on, a large number of good plans with a wide range of PTVs and PTV overlaps. We're planning based completely on dose fall-off expectations and math. And so if you use math and dose fall-off, you're going to get a better plan. So I always get significantly better plans than people that use AI. I've recently approached a vendor about using this concept. The idea is that if you can draw with a marker, different color markers, exactly where the isolose line should be, then you don't really need AI to accomplish a great plan. You just need math and dose fall-off and contours. And we could get even a little bit more advanced, but that's something that I would like to achieve in the near future as well, using a automated planning that's not based on AI, that's just based on math and dose fall-off and contours. I think that's super simple and will lead to better plans.
And Dr. Shulman, I think we have 3 people who are interested in your project, so I forwarded along the email address, so hopefully you'll hear from them soon.
Okay, great.
Yeah.
Yeah, I know we've got some excellent physicists out there with some really bright minds. So it's always nice to collaborate. We've got 150 people on the call. I'm sure that there are plenty of people that have better skill sets that I don't have. So, okay, I've unpaused it. It's just going to finish the optimization. I hope this process has been pretty straightforward for everyone. And I'll be excited to see how you all implement this into your clinics. And it'd be great if you would share your progress with us, if you have success with it. If you have questions with it as you're going, reach out to us. We'll be happy to answer. You can reach out to me too. I'll be happy to answer questions, but I would love to see some of your progress. So if you start getting some outstanding plans, share them. We'll be really excited to see it. I think RCC is working on some research projects with that as well. So yeah, please share your progress and your process and hopefully some of your outstanding results. And yeah, just keep practicing. The more you practice, the better you'll get. And hopefully a lot of you all will become better at this than me. That would be the idea. Again, the cool thing is you follow a process. I've only planned a couple cases in the last few years since I moved back to the States. So I rarely do any treatment planning anymore outside of SRS, SVRT, but it's sort of nice. I can just pick up a plan this morning. If I follow the process, it works. And so even if you haven't planned for a long time. I'm sorry, everyone, it went a little bit over, but I appreciate everyone for staying on just an extra 20 minutes.
Dr. Shulman, do you mind if I plug a question?
Yeah, sure.
So if PTV is very close to the skin, do you apply any other trick or just do what you're doing as this plan?
Yep, great question. So you never want to optimize closer than about 3 millimeters to the skin. And the reason is, so your optimizer can actually, it can do it. It can have some optimizers, maybe the newer ones. It can optimize up to the skin surface without even having hot spots. And so you think, well, why do I need to then subtract 3 millimeters? So if you do that, you can experiment at your centers, optimize something right to the skin surface. Then after you've done that, shift your PTV 5 millimeters away from the skin surface and recalculate your plan. What you're going to see is you're going to see 25 or 30% hotspots. And so it's not robust. That's the biggest thing about optimizing to the skin, is it's not robust. And so the reason it's not robust is you're optimizing right to the skin surface. You've got air right next to it. You've got no scatter, no buildup, nothing like that. It's all tangential. It's tangential with no in scatter. And so you have a lot of fluence in order to get that 100 to 105 range. And so what happens is Now, when you shift your ISO, or if the patient moves a few millimeters, and now you're treating into the skin, now you've got your buildup in your in scatter and your back scatter. It all of a sudden jumps to 125, 120 to 130 hotspots. And so one of my colleagues worked at a center where they treated a lot of vulvar cases. And the doctor would prescribe and the planner would plan right up to the skin surface. Well, it all looked great. And then at one point they looked and they said, well, why are all of our patients getting these horrible skin reactions? And they did the robustness of planning. They shifted it, a few 5 millimeters away from the skin surface, the ISO, recalculated, and they saw, oh my gosh, we're giving 125 hotspots to the skin surface with any deviation in setup or any, lots of vulvar patients get swelling. So it swells a little bit, then you just exacerbate the swelling with that extreme dose buildup. So that's why you never want to optimize to the skin surface. Oh, sorry, I forgot to hit play, guys. Sorry. If you need to cover, if you're worried about needing extra flash for something that can have swelling or setup errors, so things like vulvar cases, then you'd want to add a flash. And this is a bit complicated, I think, to explain in like 30 seconds, but maybe we can touch on this in another session, or I can send out an email to the group. Okay, so this is done. Just calculate it, take a quick glance. Again, maybe not perfect because we didn't spend that extra 10, 15 minutes in step 3, but it'll be pretty good. So the idea though with the flash is that you'd want to add some sort of tissue outside of the body, optimize on that, or bolus. There are different techniques. You can look up a number of different papers, and you want to optimize with that extra, say, cm or cm and a half of tissue. And then for your final plan, you want to remove that tissue or remove that bolus and calculate. That's what's actually being delivered to the patient. But all it does is it adds fluence out into the air where you could get swelling or buildup. So we've got 110 hotspot. We'll quickly look at that. So we'll look at, here's like 98% of my prescription. That's pretty good, pretty conformal. So let's look at about 98% of 54. Again, I was looking for 95% coverage. You can see 98 covers quite well. Also, looks pretty good. Let's look at about 6% hotspots, not too much, and it's not in my mandible, which is good. And I'm sure we could probably have done a little bit better, but let's look at 6% hotspots in 5400. You just see some spots, not bad. We've separated out our PTVs pretty well. Again, we could have sharpened it up just a little bit. And then we'll look at 27 gray. So you can see it conforming around all these organs at risk, really sparing them heavily. Here's the parotid. So you can see about 5 millimeters away from the parotid, which is what we want. Again, here, this parotid, like 4 millimeters away. Really sharp sparing of the parotids. You can see that spine sort of spared the back of the neck. You can add a back of the neck structure, as I did on my last tutorial. So I think we've ended up with a pretty good plan. And I think if you end up comparing DVHs to any other planner that works on this, you'll see that your organs at risk sometimes have dropped by 10, 15, 20 gray, which is a huge difference. So you'll be surprised how much, if you just let a friend plan it and then you plan it in this way, just how much your organs at risk have dropped. Any last questions? Thanks for staying a little bit over.
There's one final one. Is there a mean dose criteria percentage? I'm sure that for PTV.
So here's a mean dose for PTV. No mean dose. Again, this would come from your doctor. This one again is a little bit hot at 5%, or if you go to 6%, it's a little bit lower. I've been at places where I prescribe 95. It's really doctor preference. Some are 95, some are 195, V195, some are V95. So there's a big variation of what your prescription doses are going to be and what's tolerated in terms of hot spots and cold spots in your PTVs. So again, I think that's sort of doctor specific. But the main thing is you want to limit how hot it gets. So by separating out the PTVs from each other, we can limit mostly your like 6% hotspots in here to very minimal. Whereas if you didn't separate it out, you'd probably have, big chunks of 8-10% hotspot. It'd be tough to tell where that PTV is.
Another question is what normalization plans you used?
So in this case, I haven't normalized anything. This just came straight out of the optimizer. You can fine tune your normalization here. So again, you could say I want 100% covers 95% of my volume. And you could normalize it that way. That's what you want. You just have to pay attention to both volumes. So I think in this case, again, we didn't spend that extra 15 minutes fine tuning. So we're a little bit low on coverage, just a tiny bit. Here we're at 95, and this isn't quite 100%. This is 53, 50. So we're at like our 95% of the volume is being covered by 99% of the prescription dose. So we could slightly improve this with normalization, but honestly, I would have just spent the extra 10 minutes in step 3, fine tuning this shoulder so that this one's 95 and this one's 95. Because if I just normalize now, this will become even hotter and it'll make my mandible hotter. So this is just missing by about 1%, but that's just because we didn't quite spend that last 10 minutes in step 3 to fine tune that shoulder. So typically don't want to normalize too much. You want to achieve it in the optimizer would be preferable. Any other questions? I hope this has been helpful for everyone, and I hope everyone tries this process out. I'll be excited to see if you want to share some DVHs, redo some plans that you've already done. I would love to see some DVH comparisons, some head necks that you've done before, or any VMATs that you've done before. Send us a DVH comparison of after you've tried this technique for a little bit of time. And I would bet that you'll see some of your organs at rest dropping mean doses of 10 or 20 gray, which is would be pretty incredible for your patients.
Sorry for interruption. The question about the PTV near the skin for the neck procedure, can we use a bolus to solve it? Maybe try it to see what happened?
So you can use, if you don't want the bolus effect, so you would only want to leave a bolus on the patient for treatment if the doctor wants that dose all the way up to the skin. So if you've got some sort of tumor that's starting to protrude from the skin, you need something really high dose right to the skin surface, then you would leave the bolus on. If you want to just increase flash, so you want to have some fluence that's just in the air outside of your PTV, just in case you got swelling or setup errors, and that PTV is moved into that sort of air area, it would still get covered by flash, just like you would on a breast patient. So in that case, yes, that's a good concept. You could put on a bolus, plan with your PTV extending into the bolus. So make your PTV now extend into the bolus so that you'll get flash, so that you'll optimize photons into that new PTV or that temporary PTV structure. And then when you're done optimizing, remove the bolus, recalculate the plan, and see what your coverage is. If you're okay with your hot spots, your cold spots, your coverage, your organ at rest doses, now all you're gonna have is just some MLCs that are opening outside of the patient's skin surface, photons going into that air space outside the PTV. You just don't want to do your final calculation with bolus on, and you don't want to deliver with bolus on unless that's the doctor's orders. But that's a really good idea for how to achieve that flash.
Okay, thank you, bro.
Yep. Someone asked me about the highest acceptable max dose. So RTOG usually allows about 15%. I think if you optimize this way, you'll usually get about 10% hotspots, which I think is fine with VMAT. So I'll usually get max doses of around 10%. And then I'll usually look at, regions of 5 or 6% hotspots. Those regions should be, 10 to 15% of your PTV. So in my case, it's my 6% hotspot is about, maybe 15% of my PTV. I probably could have improved it a little bit, again, just in step 3, fine tuning that shoulder and the sharpness of the curve. So 10 to 15% at about 5 or 6% hotspots is good. And then your max dose of around 10% should be pretty easily achievable. Another question I see about skin flash. So maybe we need to have a session to cover this explicitly. So we use this definitely in chest wall patients and breast patients using VMAT or IMRT, but it is helpful. We use it all the time in our vulvar patients, and in other cases we'll use it. Lots of times for head and neck, we don't use flash just because we got a mask and it keeps the patient in position pretty well. We're not too worried about it. If you are worried about growth of tumor or swelling, you would want to add a flash. And again, we can think about adding a small section on just flash to our RCC curriculum from all the questions. They're very good questions though.